All right. Well, Eric, we're at the top of the hour. I think we'll go ahead and get started because we only have 30 minutes. I still see people joining. But so everyone, thank you and welcome to the new Sema4 Network. It's our live webcast series to address some of the big questions and the challenges facing us, not just in the face of the COVID environment, but just the changing landscape of healthcare. So the series today, the topic will be led by Sema4's founder and CEO, Dr. Eric Schadt. Eric will address what we're calling the seismic shift post-COVID-19, the testing and the digital health revolution that is upon us. Eric will discuss kind of the global landscape of the pandemic and also how Sema4 is helping to relieve some of the pressure on health systems by developing COVID-19 testing. And again, a deeper dialogue around the digital health revolution that's taking place right now. Just some logistics notes. We are recording this webcast, so if we don't get to your questions, it'll be posted, and we hope to address all the questions and comments that come. Your lines will be muted throughout the call, but we do welcome and encourage you to ask questions and make comments via the chat feature of Zoom. So Eric, with that, I'm going to turn it over to you. Thank you.
Okay, great. Thank you, Bridget, and welcome everybody to this special fireside chat on the kind of what we're faced with and how we're handling on the COVID crisis front, and of course, knowing that we're not alone, and looking forward to your feedback and input, and maybe some of the experiences you have going on. And of course, we all know like how amazingly transformational this sort of event has been. Don't need to go through all the numbers. I know the media covers it extensively, but I'm sort of struck on how much it changes even all the day-to-day life in kind of subtle ways. And the one, before I get into some of the science I wanted to highlight was how how it's changed even subtle things in the family front, with everybody locked down and in the home, and with my daughter, who is known to like riding big wheel bikes and read these types of stories, now all of a sudden wanting to dress up, be like Santa Claus with all the digital engagements with friends, and now all of a sudden seeing versions of these stories floating around that require the dad's editing. So it's been, I'm sure for everybody can relate to some of the at-home experiences. So before I get into kind of what Sema4 is doing in particular, thought worth going through from a domestic standpoint, and us on the East Coast, how this all came to be, how this virus got here into our part of the world, how likely widespread is it, and so on. This is kind of the visibility we're trying to gain, both with the state of Connecticut and helping them institute programs, working with them to institute programs to both better understand the outbreak and get people back to work. There was a nice paper in Cell out by the Yale group and colleagues, basically sequencing a number of the viruses that had shown up here, in addition to across the country, using phylogenetic analysis to assess where are the cases that are flowing through our state, where are those coming from, and interestingly showing pretty solidly that they came largely from the Seattle, Washington area, and that the sort of the biggest domestic uptake initially in the early days was in Washington, and that given the travel importations and so on, what likely happened in Connecticut was that transfer via travel from Washington into Connecticut. There's also this idea, like, we haven't still done any population-based screening to really assess how widespread are the infections, what's kind of the rate of individuals being affected and infected and being asymptomatic or subclinical. So we're eager to start doing broader-based population screening. But in the meantime, there have been a few papers went out recently by Decode in the New England Journal and another earlier paper in Science doing simulation on data that was collected out of the Wuhan and related areas in China, and estimating that they thought up to 90% of those who are infected potentially being subclinical or asymptomatic. And of course, Decode, having done the largest population-based screening that's been done to date, publishing their results in NEJM that showed that roughly 50% of those being tested were either asymptomatic or subclinical. So seeing this, that likely it's a much bigger, much broader rate of infection and spread than we had anticipated. And in this paper, I liked how they used the viral haplotypes to try to link infectivity patterns, transmission patterns. So this is showing a contract tracing network that was constructed from the viral haplotypes of who would have gotten what from who. And if you zoom into the clusters that are indicated here, you see the individual to individual transmission and what form of the virus they had, what haplotype they had, and so on. So it's a pretty interesting information flow, probably the most comprehensive done to date, in demonstrating that most of the spread that's been seen in the Icelandic population came similar to what the Cell paper says on Connecticut, from travel into the region, and then increased spreading once those carriers landed through the families and social interaction. So that kind of raised the question, as the testing demands increased, and as we and others saw the need to do more population-based screening, we wanted to see whether we could contribute to both relieving the load and also helping launch some of the studies we think should be done to help us get a better handle on what's happening with with the COVID-19 disease. So as you all know, there are two types of testing: the nucleic acid based testing and antibody testing, where the nucleic acid testing is really serving only to identify those who are actively infected. So these are ones where you're either getting a nasal swab or laryngeal swab. They're generally PCR based, quantitative PCR based, although there are alternatives to that approach. Minutes to hours in terms of turnaround time to actually execute on the assay, which is not the same as saying, what does it take to clinically report out? That could take a little longer if it's not a point of care device. And on the antibody testing side, it's really serving to identify those who have been either recently infected, so showing IgM positive antibodies to the infection, or those who had been infected at some point in the past and have mounted some sort of defense against that. So you would be IgG positive on the immunoglobulin front, and sort of the kind of test you're seeing come to play here that's more qualitative point of care is listed at the bottom here, where you'll just see the bands almost like a pregnancy test on whether you're carrying those antibodies or not. And this can be done as a test that can be done point of care, maybe even at home at some point in minutes. And blood and plasma, blood plasma and serum are the medium that you're carrying out that test in. So given the need, the demand for that, we did come out with our own test, really driven by the state of Connecticut and wanting to relieve a lot of the testing burden and slowdowns. They were seeing 5 to 10 day turnaround times. They were desperate to, especially those in the hospital, if they could determine that they were or were not infected, would determine whether they should stay or leave the hospital. And of course, taking beds that could be used by others that are more severe was, I hope that's not because something's going on here. Is there? Are you hearing me okay, Bridget?
Yeah, I was muted. Yeah, we can hear you perfectly. Thank you.
So I only answered the phone because I was having the horror thing of I've just been talking for 10 minutes and nobody was hearing.
Yeah.
So I'm grateful that it's that. So we have this test that was intended to meet this demand. that we're now running. We set it up at, relatively on the lower side of the throughput, 6,500 samples a week. So we can do, 14 to 1,500 a day, 24-hour turnaround time. And really, we view this as trying to get most of the stat samples. So these would be where some of the bigger labs that are overloaded and so on, taking 5 to 10 day turnaround times. Some of these hospitals need it, within 24 hours, and we're able to meet that demand. So we're happy about that, and are also in the process. And for the positive cases, we're sequencing with collaborators the viral genome and contributing that to the growing repository of genome, so that you can get at the kind of figures I was showing in terms of how this virus is being transmitted and diffusing throughout society. We're also standing up several antibody tests. On the antibody side, we're focused mainly on the quantitative antibody titers that we think will be very complementary to the types of tests, point of care tests that's depicted here at the bottom. Just because we think, like, to really understand the immunity, like, what are some of the questions that remain to be answered about this, that you'd want to do a more quantitative, accurate assessment of antibody levels. So we, again, at this point, don't know the true rate of infection. We don't understand the dramatic variations in response, from those who are completely asymptomatic to those who are subclinical to those who have mild disease to severe. We don't know when a good immune response has been mounted. Again, understanding the quantitative level is important there. If you carry the antibodies, are you immune to reinfection? And if you are immune, if you've mounted immunity, how long will that immunity last? And so on. So all of these questions, right, demand larger scale population screening, not just a nucleic acid test, but the antibody test as well. And so we're involved in a number of studies going on, both in the state of Connecticut, but also with the Mount Sinai Health System, helping sequence, so Mount Sinai at the epicenter of all of this that's happening, just catastrophic. But for those patients who were hospitalized severe, Sinai has a program going on of sequencing all of those individuals, tracking them over time, taking samples over time, doing DNA, RNA sequencing, mass cytoph, cytokine panel screening, and so on, all geared towards, can we develop a better understanding of this disease, why it gets so severe, how to distinguish between those who will have a severe reaction versus not, and so on. Not unlike, obviously, many people around the globe focused on that, but what you have in New York City are the numbers, really high numbers of thousands and thousands of patients who have been treated in the hospital. One of the studies I'll say a little bit about is, a study we're in the process of launching with Mount Sinai that's focused on pregnancy. So the map that you're seeing here is indicating the density of women across the New York City area that have at least one risk factor that serve as a risk factor for COVID-19 illness, for severe forms of that illness. So those having those that had delivered in New York City. So there's obviously a lot of risk represented in that area. Roughly half of all deliveries within the New York City area and the boroughs occurs at a Mount Sinai hospital. So again, we have really good sampling through the population of the pregnancy population, and of course, New York City being very diverse, we get all the different racial and ethnic breakdowns, as well as the socioeconomic. So just an amazing resource. Sema4 has a unique patient engagement with those going through the pregnancy journey who are being tested with Sema4, where we have the ability to recontact those individuals and get them enrolled digitally into the trial. So during the lockdowns and so on, we don't have to have them flowing into the clinics. We can do it via text and email, and they can run the app. And of course, the aims of this are characterizing women through their pregnancy, whether they get infected or not, how severe the response is, and trying to understand the risks of the severity of those infections, the impact on mental health, something that's very understudied. The differences across the socioeconomic line, something that's also not well studied in this context. And of course, the impact on complications of pregnancy. How does an infection impact your risk of preeclampsia or perinatal depression, hemorrhage, preterm birth, and so on? So I'm partnering with the Mount Sinai OBGYN on this to get this launched. What we have to really facilitate this is pretty good mastery over all the pregnancies that are flowing through the Mount Sinai health system. So we collaborate with Mount Sinai on being able to reconstruct all the journeys of pregnant women through their course in the Mount Sinai system or their affiliates. So we have many, I think we're up to probably 200,000 or so pregnancy journeys that resulted in deliveries where we have good longitudinal data through the course of the pregnancy. So we have mastery of all that information with the ability to recontact. And our strategy is going to be one of being able to leverage samples that are coming in for testing if the patients are consented, in addition to additional time points all the way through to delivery. Where we'll be collecting blood samples. In some cases, we'll be able to get placental and cord blood. And then we'll be running, as depicted in this slide, a host of molecular assays, all geared around, can we identify biomarkers that better predict your risk of a complication, even your risk of infection. They're going to be genetic determinants on how easily you can take up the virus, not to mention the host response to that infection. So those are all the parameters that we'll be looking at through this kind of data set. And again, focused squarely on pregnancy, and given Sema4 has a major component of its business on the women's health and reproductive health side, we're super excited to be able to make this kind of contribution to the understanding. And then ultimately, what we're going to be doing with all the data that's collected is run it through the same types of machine learning and probabilistic causal reasoning models that we use in the normal course of business, even in predicting complications of pregnancy as depicted here. We'll apply that same kind of machinery to analyze those data and come up with new ways of identifying patients at risk for various complications and risks of infections and so on. And what you're seeing here is one of the outputs we have coming in a paper that shows the risks of preeclampsia. This is not in the context of the COVID infections, but is just a demonstration of all the data that we have across hundreds of thousands of women that went through pregnancy, where we have all their medical record information and have reconstructed the longitudinal journey of the pregnancy, and through that are able to, by time, predict what their risk of preeclampsia is over the course of their pregnancy. And what you're seeing in these this blue curve here is our predictor, the positive predictive value over time at the Mount Sinai Hospital, the main hospital, versus the blue curve down here is the current standard of care assessment. So our positive predictive value for assessing whether you're at risk for preeclampsia is 3 to 5 times higher than the current standard of care assessments. So this is the kind of machinery, the kind of predictive modeling we'll be able to throw when we layer in the COVID infections as well, where we'll be able to start assessing the interaction between the COVID infection and these various complications. And again, wanted to highlight in particular the healthcare disparities, mental health, all of these issues that plague disproportionately to the underserved communities, partnering with Liz Howell at Mount Sinai to just better understand and study that in this kind of cohort. Longer than I thought, but yeah, we'll pause there and would be very happy to take questions.
Awesome, thanks, Derek. That was actually great. So just a reminder, at the ribbon at the bottom of your screen, if you happen to be dialed in on a computer, there's a Q&A bubble, so please submit questions there. We do have a handful, Eric, for you to tackle right now, kind of coming in groups. But one question was around the fact that there's greater than 200 genotypes for the COVID-19 virus. Do you believe that Sema4 will be able to identify these at some point? And what does our research look like on this front?
So Bridget, unfortunately, as you started asking the question, I started reading the Q&A. So
Yeah.
I missed the very first part of the question. So if you could repeat.
Oh, so the question that came in was, there are greater than 200 plus genotypes for COVID-19. Do you think Sema4 will be able to identify these at some point? And are we doing research on that front,
Yeah,
on the
so
genotype?
perfect. Yeah, so absolutely. So again, through the testing we're doing for the positive cases that we identify, because it's a good point that the PCR based, more a simple sort of an assessment is just really detecting presence or not of the virus. For those positive cases, we have several collaborations, including with Mount Sinai, to go and sequence the viral genomes that come from those positive cases. And in that case, you'll get the genotype, the haplotypes, and those will be contributed to the growing repositories.
Awesome. Another question that came through was for IVF centers, as we look to treat patients safely for IVF treatment in this COVID environment, what do you think will be the state-of-the-art way to test patients and staff for COVID? And, what do you think is a reasonable timeline?
Yeah, so this is exactly what we're involved in, working with several other groups with the state of Connecticut, and like what's the right kind of protocol you want to put in place to let people go back into the workforce or go back into going to their appointments at IVF centers and so on. So we think the strategy will center around, and we're working with a couple of IVF centers today to sort of flesh out whether this kind of protocol could work for them. But there is point of care testing, like if it's lower volume, Cepheid and others have point of care, RNA-based, PCR-based detection of the virus that can be run at the point of care in 10, 15 minutes. The antibody testing is also a complement to that. And Henry Schein, One Milo, probably 15 or so providers of that will be flooding out of point of care antibody testing. And so we think assessing whether somebody's infected on the spot, that would cause you to counsel such a patient around going into quarantine. So that would be an actively infected patient that can communicate that to others. The antibody testing will help give comfort on whether you've already been infected, and so likely are immune. The studies, though, we're wanting to run with the state will track, in particular, healthcare workers over time to see if those carrying the antibodies maintain a resistance and immunity to that disease, so that we can learn as we're going. But I think it's going to be some kind of combination of being able to test patients as they're coming in, whether they're infected or whether they have already mounted an immune response and so are protected from being infected again.
Yeah, awesome. There was another question around, high false negative testing results. Some of that might be attributable to logistics of the specimen collection, which may not be technology in the lab. What measures do you think industry could take to minimize false negative test results?
Yeah, so the false negative, so I'm going to put that on pause a little bit because I saw the tail end of the question that I just answered was on reasonable timelines. What we're trying to do, at least in the state of Connecticut, is by the end of May, have a program that can be put in to place. And again, the scale of testing needed, if you think about not just IVF centers, but you think about, all the other jobs and appointments that people are going to want to be going to, the scale of testing that you need is going to be beyond what the point of care can support. And so we are looking at being one of the high throughput providers where you can imagine people going and getting tested at a test center. So we'll have an app and they can go and put in where they live. It will assign a test center. They'll get tested. If they're not actively infected, they'll perhaps have to fill out a daily survey, take a temperature check, and so on. Like there's that, those who are infected or those who carry antibodies would be given a either a quarantine type order, so stay locked down because you're actively infected or you may be immune. You're free to go to work. So there's like, those are the kinds of programs we're trying to come out with, what's going to work, what's going to be tolerable, there's the balance of freedoms and personal liberties versus protecting society and getting our economy back. So we expect over the next month that some of those protocols will be nailed down. On the false negative rates and lowering those, there's a couple of things there. So first of all, the quantitative PCR tests are clinical grade, right? So they're super high specificity and sensitivity if the virus exists and is in the well being tested. If the collection procedure isn't done right, so there are enhancements being made to the collection procedure, instead of having to stick something way up your nose or down into your tonsil, there's the saliva collection, which Rutgers has shown is equivalent to those more invasive type swabbing. There are alternative digital display type PCR technologies that use nanodrops and encapsulating things that would be amplified via PCR, and these droplets that work way more efficiently, way more sensitively in the context of very low titers of virus. So you can imagine, and if you don't do the swab exactly right, or you're just have low levels as a person, those can be harder to detect. But some of these technologies that exist or have the ability to go deeper, but it's at this point it's more, you need to, if they're clinical tests, you got to get some sort of approval or waiver from the FDA. So I think what you're seeing is this lag in being able to get those kinds of tests up and going versus tests like the standard quantitative PCR tests that were just easier to stand up because they were the technology was just existing and in that framework already.
Yeah. So just a reminder, there's lots of questions coming through either the Q&A or the chat function. So thank you. We're going to try to get to all of them. Eric, there's a series of questions that came through around what, I'm going to call telehealth, telemedicine. And, how do you think the patient opinion and physician approach will be different post-COVID? And how does that change or advance capabilities for virtual medicine? And, just what's your perspective?
Yeah, I mean, my perspective is it's clearly going to be transformational for telemedicine. I think it's something we all who focus on digital technologies and software and apps and patient engagement have been wanting to come or knowing it could come. This sort of event, catastrophic event, but necessity breeds that sort of experiment where I think what we're going to find, just as we're finding how effective it is to work at home in a lot of cases, to have these sorts of conferences remotely. We'll also find that a lot of doctoring can happen remotely, that the technology exists, and that the state of care could improve, right? I think if you're being seen more often, if the engagements are more seamless, more automated, the tracking abilities are more expansive and so on, that the understanding of your health is going to be better and the input from physicians is going to be better. So I'm pretty bullish on, that one of the positive consequences of this is going to be a new state of healthcare delivery through the telemedicine and digital means.
Good. There's another set of questions that kind of follow that are kind of thematic, and it's when will antibody testing be available from Sema4, and then the concept of everyone's hearing about shortages of supplies and kits. And do you see an end in sight for that?
Yeah, so it's a good question. We're getting, first of all, the RNA-based test kits to scale to be able to do 100,000 or so patients a day, just in the state of Connecticut even. The kind of swabbing kits you need. So we're getting EUA approval on swabs that can be generated in mass through 3D printing and a number of providers. And once we have EUA FDA approval, I think the shortages, at least from our standpoint, are gone. On the antibody side, those tests are already here and coming. It's a matter of scaling up. Like they're all busy in Korea and other locations generating enough of the proteins and stuff to make enough strips, and that's like all going in mass. And I think the timing is maybe 20 to 40 days where you're going to start seeing just massive quantities of that kind of testing being made available across the systems across the country. So I think it is going to get addressed in the coming month.
Okay. And let me just throw out one more question. So we asked the question about false negatives. Now there's a question about false positive antibody testing. And do you think it diminishes its effectiveness and therefore could give a patient a false sense of security going forward? Do we really feel like the testing can distinguish between COVID-19 and other common coronaviruses?
Yeah, it was one of the concerns earlier on in the antibody setting was cross-reactivity. Our view, and having done a number of the tests and working with other groups that are comparing these head-to-head in positive and negative samples, known positives and negatives, that these antibodies are pretty good. They do seem very specific. But that said, the numbers are not huge. And I think what we have to have an obligation to do as we start rolling this out are some protocols that are doing the right kind of tracking on our individuals who are carrying these antibodies getting reinfected. Are they getting infected again? Is that a result of not the right level of immunity, or was it not a specific enough antibody? Like those are all the assessments we have to be doing in real time. And that's one of the exciting things I think that's coming out of some of these initiatives, is that learning, adaptive learning will be going on in real time. In Sema4, I should say, we will have hopefully the antibody testing quantitative, more accurate version up and running, hopefully by the end of next week.
Pretty awesome. And we're at time, but there's one more question that I think didn't fall into the category of some of the others. And it's, do you believe the testing done by Sema4 would be able to shed some light on disease mechanism, which could ultimately help with treatment strategies?
Yeah, so what we're doing in collaboration with others like Mount Sinai is we're sequencing the positive cases. So for example, for the biobank at Mount Sinai, where we're the partner sequencing that biobank, of course, there are a number of cases there that are positive. So we've accelerated sequencing of those patients, and they're pretty good numbers. Again, Mount Sinai has big numbers. Those data are being combined with UK data, with data from China. And so massive, and probably many on this call are involved in as well, but massive studies going on right now to try to identify, are there loci that modulate your risk of infection, severity, and so on? Like, can we start getting biomarkers, reads on biomarkers that may be predictive this way? Yeah, and we're very actively involved in that.
Awesome. Thank you, Eric. So we're past time, so I appreciate all the questions that came through. Just as a reminder, we will post this on our website, a recording of it. But if we didn't get to your question or want to engage in a different dialogue, in the original email or invite, there was an email address to our marketing team. So please don't hesitate to respond there. And we would love to hear from you about other topics you'd love to see Sema4 tackle.
And I'll say, Bridget, not to cut in, but any pointers or any, we're all learning this together. Obviously, it's just a crazy time. And any advice or special pointers or collaborative ideas, we'd love to hear that as well.
1000%. All right. Thanks, everyone. Have a great weekend.
Yep. Thanks, Bridget.